Go. Okay, I should be recording this. This is just gonna highlight a few things that are possibly important. Now, our quizzes are not necessarily going to focus on pharmacokinetics and pharmacodynamics, but it is a huge part of pharmacology. And really, pharmacokinetics and pharmacodynamics are also should be a huge part of botanical medicine. They're also these topics are also kind of boring. I'm just going to come out and say it. So let's highlight a few that are not quite so boring. Now, I personally put a lot of effort into the pharmacokinetics because I think there is more information. And as you can see at the top, second bullet point at the top of the page, I wanted to do some integration of how botanicals could be using this model. And silymarin, which is the most, not the most, is one of the more studied compounds. Of course, silymarin is not just one compound, and it works in the liver in multiple mechanism and compare that or at least discuss it with some of the pharmacokinetics parameters of a statin, atorvastatin, which is one of the more popular ones. So recall that we need to have something absorbed. So the route of administration matters for this. So the route of administration for both of these is oral, PO, which does impact bioavailability because they both have to go through the liver and first pass of the liver. Um, so this bioavailability has some specific information, and I haven't I've talked about this in nutrition classes when I've taught them, but I've never really gone into the factors that describe or calculate bioavailability, which is listed as F in a calculation. So here, let me go down to this whole thing. Um, so you must have the dose. And we're thinking about doses orally and IV and the area under the curve. So that means this has been tested somehow. We can't just calculate the bioavailability based on one patient because I don't have the ability to test all the compounds in herbal medicine for that one patient. But knowing how much of a compound is under the curve and then comparing that to the oral dose, the IV dose, um, can give us our bioavailability. So here the drug is taken, and then the area under the curve is how much is basically in the body. So at the top here, it's the maximum point, which is described as C max, the highest concentration in the blood. And then elimination and excretion happens. Now, in this case, we're also talking about elimination being a combination of excretion, which is the typical term associated with pharmacokinetics, but elimination also includes metabolism. And both of these drugs are metabolized in the liver. Um, in here, there's time to peak concentration. Also, that's listed as a factor, not necessarily for bioavailability, but just something to know that that exists. Now, half-life is the one to really think about, time at which a drug have lost its maximum concentration. So why is this important? So bioavailability, of course, we know about when we're thinking about how bioavailability is curcumin, is silymarin, is certain B12 variations, because that plays a part in how effective those compounds are. And then the half-life will tell us, oh, how frequently do we want to dose this? The difference between our medicine and the framework of, say, botanical medicine or some of the specialized nutritional formulas is we want that steady state, that area under the curve, to be reasonably significantly high throughout the day. Maybe it will dip, but it really should not get to C min if we want the most efficacious treatment plan. So having that nighttime dose of something, no matter what it is, will be very helpful. So, those of you who know Dr. Eric Yarnell and have met him at conferences, he has talked about this a lot. I often remember to do this. I am a huge fan of twice a day dosing because people are more compliant. But what happens? They run into the Cmax or Cmin where they lose that effect. And it's like the body has to, you know, get back here the increasing area under the curve to have a therapeutic effect. So that's a little snapshot on the importance of these particular factors. Bioavailability is a subset of absorption. So that's why it's talked about significantly here, whereas half-life is a little bit more um, associated with excretion. Now, there was something I wanted to say in here. Oh, here. So some of this is in italics and some of this is not. But Silymarin has poor bioavailability. It's composed mostly of flavonolignin, so that makes sense. A lot of flavonoids are not very bioavailable, but we have these awesome phytosome forms, the phosphatidyl cholated, for lack of a better term, which definitely helps with that. Um, and this particular statin's bioavailability is 14%. It has extensive first pass, and it also has some additives in there. Now, these two compounds, again, are liver is their primary target. Okay, so in distribution, we want to think about blood flow. In the Pharm 1 class that I just went over some of this information of, I think like I think blood flow is really important. And with that, when I think about blood flow, I think about blood flow through the kidneys because that's also going to be a huge part of excretion and elimination, but especially excretion in our pharmacokinetics model. But plasma protein binding. So only the free drug can have a therapeutic effect. So if somebody has a protein deficiency and maybe they actually have low albumin, that means that drug is going to have more of a therapeutic effect, which means there might be more side effects. Now, if I haven't said this already, these factors ideally should be factored into a specific branded drug and that dosing strategy, say of statin, say of Wellbutrin, say of fluoxetine. Um, we don't have that for botanicals. We do have a little bit in excuse me, in the vitamin world. Okay, so I feel like I was just talking about the volume of distribution, which of course is related to distribution, and it sort of is theoretical. Um, so here, this is maybe not the best graphic, but I thought it fit in well. So this is the drug. It's 1 gram of the dose, and here's a compartment, and then the concentration in the region is low. Um, and some of that might be due to protein binding, some of it might not. But here, silymarin distributes extensively in the liver, stomach, intestines, and pancreas, which I think is super cool. Because we know silymarin and other milk thistle compounds are beneficial for diabetes. There's non-extensive study on binding, but we do know distributes pretty extensively to those tissues. I love this. It is highly, highly concentrated in the bile. Um, 60 times higher than other tissues. And remember, bile goes through enterohepatic um, circulation. So this silymarin that is concentrated in the bile perhaps can go through that recirculation of the bile several times, depending upon its factors. Now, atorvastatin is got a plasma binding protein that is 98% primarily to albumin. Albumin is this ARC-type protein carrier. It binds to a ton of stuff, or maybe more specifically to say a lot of stuff bind to it, but it's really super loose, so it can let go of it and have its site of action. I included some body compartments, which are helpful to identify the volume of distribution. And then I tried to, this is theoretical, the examples of natural compounds. Metabolism, we know really well with our focus on the gut and the liver. So I'm just going to go down to milk thistle and atorvastatin. So look at this. So this is one of the things I found a bunch of articles. I pulled the information, and this is when I started having these discussions or chats with a ton, at least I'm going to say five different AI programs. And a couple of these are meant to be conversational, which is still kind of weird. Um, but it was able to put it in what I do think is nice and condensed, and then I helped it along a little bit because the AIs are not always truthful because of their hallucination. So silymarin is mostly metabolized by CYP2C8, which is not one I think about in the scope of drug interactions. There's conflicting reports on other CYPs that are involved in it. 1A2, which is really interesting. That's one of the ones that acetaminophen works on. 2D6 metabolizes a lot of drugs. 3A4 and 5 metabolizes a lot of drugs. Now there is some research on silibinin, depending on how you want to say it. I think there should be another I for me to say it like that. Um, because it is possibly more powerful than silymarin as a group of different compounds. So that is also metabolized by 2C8, and then it's got its byproduct there. And then here we have atorvastatin, which is CYP3A4. So CYP3A4 is one of the ones that has been highlighted in my past. So I was just thinking about this. It was about 20 years ago this year that I started doing some writing for a supplement company, and this drug metabolism and CYPs was one of the things that I focused on in some of my articles. Excretion is exactly what it says. I'm going to just highlight this part here. What is going on with the kidney health? Do CMPs, not BMP, because a basic metabolic panel sometimes is missing the kidney parameters. Um, and I was just telling the Pharm 1 students in a recording on pharmacokinetics that last year I saw a young man who I believe was 28. He was a bit overweight. He did have a lot of congestion. Oh, he also had ear stuff. So I sent him to um, ear, nose, throat guy to take a good look at his ear, and some interesting things in there. But he also had a low GFR, 28 years old, which was really, really concerning to me. So would he process drugs the same way? Probably not. And then, of course, people that have issues with their liver health and bile, say this might be somebody that has hepatitis C, as well as is not getting good quality fats, because we need to have phosphatidylcholine not only for cell membranes, but it is a huge part of bile. So this is where a little tidbit. So let me delete that part. Silibinin is excreted in the bile, but undergoes extensive intrahepatic recirculation, could be resorbed in the bloodstream. So how often, how many times does that happen? Super cool. Now, elimination is that combination of metabolism, because a CYP can metabolize something and make it not active, and then it's just going to be excreted. And then there's excretion, which is independent of metabolism. And this is where first and zero order kinetics fall into. So first order kinetics is where the rate of elimination is proportional to the drug concentration, which basically means it will be dependent on the drug dosing. Um, I'm trying to think, oh, I can compare this to, this could have been interesting, acetaminophen. So acetaminophen comes in tablets of 325 as well as 500 milligrams. So that's going to be a little bit different. And I do believe acetaminophen follows first order kinetics as well. Zero order kinetics is where the metabolism is constant and the concentration of the drug doesn't necessarily matter. So those two things are kind of interesting. These, excuse me, again, I was just sucking on a lozenge because I am still recovering from some kind of respiratory infection. So clearance is really just a measurement of the substance being removed of the body per unit of time. So again, this is something that should be listed in your resources. Let's see, I might try to look one up really quickly while I'm talking. So the Davis Drug Guide is one of the resources I use, and I do have it. So the Davis Drug Guide includes half-life. It includes onset of oral, the peak, and the duration. I actually don't see it specifically describing clearance, um, but it does talk about metabolism and excretion. Again, that would be termed elimination in this model of pharmacokinetics. Half-life, of course, makes perfect sense. And it can be very helpful for just kind of keeping an eye again on dosing and dosing strategies. So 6 hours is the half-life of silibin. So this might be something that you could dose BID versus TID. Or I actually do like milk thistle products as a nighttime dose because I do think that information that has been discussed, and I haven't run into it in my pharmacological studies so far, that the liver does a lot of activity and regeneration at night. I think taking liver herbs before bed at night and having them be a part of that regeneration is something I would like to see. So I do often do that for patients as well as myself. And then this is just kind of thinking again, dosing is part of this. And again, dosing could be personalized medicine. There's a whole nother page in there. The the factors that come in with pharmacology, like here I have acetaminophen open on the phone, um, and it's got dosing parameters, route and dosing. So for adults, there's actually 650 milligrams forms, which is basically two 325. Um, so when we know more of these pharmacokinetics and potentially pharmacodynamics, when we have that for natural products, that would provide many, many more dosing strategies to have more success. So there is this concept that I have seen off and on in practice, that patients are comparing their herbal and nutritional supplements to a pharmaceutical. And again, I'm going to reference Dr. Yarnell. We might not be dosing high enough for that because we don't have that information. So, okay, sorry for all the babbling with this. Please let me know if you have any questions. Just our short review on pharmacokinetics, um, which I think is more interesting than pharmacodynamics, which are a little bit more challenging. And I will do that recording later today or early tomorrow. Um, and maybe I'll be on the camera. Sorry, I'm still disheveled because I'm not really feeling well. So I've not been on the video all day. Have a great day.